Thank you for coming to tonight's program. My name is Luke Andreso, and I'm an intern here at the Jefferson. It's my pleasure to kick off tonight's event, and I need to do three things. Go over some housekeeping notes, tell you about some upcoming Jefferson events, and introduce tonight's presenter. First, some housekeeping. If you need assistance during the event, please feel free to find me. I'll be happy to help you. Some reminders for the Q&A portion. After the presentation, please raise your hand to be called on and project your voice as best as possible so our speaker can hear you. And please try to keep your questions brief and concise and refrain from offering lengthy statements. Now on to an upcoming event. On Wednesday, June 25th, Dr. Devani will deliver a lecture at the Jefferson Educational Society called The Erie Accent. What is it and how has it changed over the past century? Lastly, I'd like to introduce you to tonight's presenter, Dr. Lori Dulabon. Dr. Dulabon is board certified in urology by the American Board of Urology. She received her medical degree from Erie College of Osteopathic Medicine and completed her residency at SUNY Update Medical University in Syracuse and at New York University Langone Medical Center, where she served as chief resident. Dr. Dulabon specializes in general urology, including male and female voiding dysfunction, urology, incontinence, benign prostate disease, kidney stones, and urologic cancers. In her spare time, Dr. Dulabon enjoys traveling and spending time with her two children. Without further ado, let's give Dr. Dulabon a warm JES welcome.
All my spare time. Thank you. Well, thank you so much for coming out. Everybody was wondering when summer was going to be here, and I think it's upon us now, so it's a little warm. But so again, I'm born and raised in Erie, so thanks for coming. And like Luke was saying, I did my urology training at NYU and Manhattan, and did my osteopathic medical school here at LECOM. And I decided to come back and practice here, and I met my husband here, and I have a wonderful family here. And so thank you all for coming. So I'd like to talk about some common reasons people come see me in my practice and some recommendations to optimize your own urologic health. So some objectives for today: I'd like you to understand some of the basic anatomy and function of the GU system, also known as the genitourinary system. Review some of the most common reasons someone may need to see a urologist. There's lots of them, but we're going to hone on some of the most common ones today and understand some general guidelines to optimize your urologic health. So the genitourinary system, or GU system, is it's amazing, complex, intricate network of various anatomic and physiologic components that help do all these different things. Obviously, urine is a waste product. It helps excrete toxins in the urine. It helps maintain volume status by triggering the renin-aldosterone-angiotensin system by and concentrating urine in times of dehydration. Like today, if you weren't drinking enough fluids, like you might notice that your urine's a little darker in color. Again, it regulates blood pressure through that renin-angiotensin-aldosterone system by vasoconstricting blood vessels and raising blood pressure for various reasons. It helps regulate electrolytes and acid-base balances. The kidneys have the ability to either secrete or reabsorb hydrogen ions or acid molecules versus bicarbonate ions or basic molecules, depending on the physiologic pH of the body. We have a very narrow range of homeostasis in the body. The body doesn't like to be too basic or too acidic. So in order to keep that range between 7.35 and 7.45, which is the optimal pH in which our cells function, the kidneys are integral in that. It also secretes a hormone called erythropoietin that stimulates your red blood cells, the bone marrow, to produce red blood cells, so the kidneys help prevent anemia. And lastly, it helps aid in sexual and reproductive function in men. But here's a little pop quiz. Didn't think you were coming here tonight and getting a pop quiz. So, true or false? Urologists only take care of men. False. That is true. And you can see by the demographics of the audience today that yes, we take care of both men and women to treat any condition involving the urinary tract in men and women, as well as the male reproductive system. So just a little anatomy here. As you can see, the system is pretty, in the upper tract, you can see you have these two adrenal glands that sit on top of the kidneys. Okay, they're very similar in male and females. You got ureters coming down and enter into the bladder. It's not until you reach like the level of the pubic bone where the male and the female system is quite different. And men have these persnickety little organ here called the prostate, which is a male sexual organ that secretes fluid to the seminal ejaculate, but it becomes quite a nuisance as men reach their 6th decade in life. And then you also have the external genitalia as well. So otherwise, the upper tracts are quite similar. Lower tracts can be have some anatomic differences. So common reasons to see me. One is prostate cancer screening and treatment. Kidney stones is a very common reason people come see me. Recurrent urinary tract infections, benign growth of the prostate that can cause urinary obstruction and outflow obstruction, voiding dysfunction, which is just basically the inability to keep the urine in effectively, leading to potential urge or stress urinary incontinence, versus the inability to get the urine effectively out due to urethral stricture disease, that BPH condition, neurologic conditions, people with spinal cord injuries, they have conditions called neurogenic bladders where their bladders just don't contract anymore, because the bladder is just basically a muscle that's normally in a resting state, and it only contracts when it's socially appropriate, when you're sitting on the toilet. And for various mechanisms, there can be derangements in that, and people can ineffectively empty their bladder. Patients also come see me for blood in the urine, whether it be gross, which means you can see it with your eyeballs, a various color range of from, I say, watermelon juice to it looks, thick and dark like ketchup with clots, and any color in between, including cranberry juice and Merlot wine. Sorry for all the food analogies, but it's a good way to describe it. Versus microscopic hematuria, which is defined as greater than 3 or greater red blood cells in the urine under the microscope. People also come see us, as I mentioned on the previous slide, for potentially male sexual dysfunction, infertility issues. Urologists can do fellowships and go into renal transplant surgery. So there's a huge range of the different facets of urology and what we deal with. But then one of the number one things that I see in my practice is patients that want to be screened for prostate cancer, have concerns for prostate cancer, have prostate cancer, are actively being treated for prostate cancer, or have undergone treatments for prostate cancer. So based on my previous slide, you can have urologic cancer anywhere along the urinary tract. Head and shoulders above all other GU organs, prostate cancer is the most common. There's about 300,000 cases of prostate cancer diagnosed annually, which means unfortunately 1 in 8 men in this room will be diagnosed with prostate cancer at some point in their life, and 1 in 6 African American men will be diagnosed with prostate cancer. African American men, for some reason, we don't yet know why, they have higher rates of disease and higher risks of high-grade cancers. Just to compare prostate cancer to lower urinary tract or bladder cancers, there's about 80,000 cases of bladder cancer diagnosed in the United States annually, as opposed to the 300,000 prostate cancer cases. Kidney cancer, about 70 to 80,000. Testicular cancers, there's about 9,000 cases annually in the United States. Penile cancers are extremely rare, about only 2,000. And thankfully, adrenal cancers are even more rare. We don't even have guidelines on how to treat it because it's so rare. About 500 cases annually in the United States for adrenal cancer. So as you can see, prostate cancer poses a significant risk to men's health. It is the #1 cancer diagnosed in men annually in the United States. Okay, so you can see, again, these are a little bit old slides, but it hasn't changed. It's a distant second, however, behind lung cancer for deaths or mortality rates. So here you can see, again, estimating nearly 300,000 cases. This is from 2024, I believe. But an estimated 5-year relative survival rate of nearly 98%. So that means we're doing a very good job at not only screening for it, diagnosing it, and treating it. Here again is just to reiterate, the comparison. Prostate cancer is just behind cases of breast cancer in females. You can see, the death rates for prostate cancer, about 35,000 annually. But compare that to unfortunate pancreatic cancer, 66,000 cases annually, and nearly 52,000 of those patients die. And again, based on the SEER data, the surveillance, epidemiology, and end results data, the 5-year relative survival rates for localized prostate cancer is greater than 99%. So again, that kind of implies that when it's caught early with our screening modalities that we have, 99% 5-year relative survival rate. If a patient even has regional metastatic disease, which means that it might have spread to the pelvic lymph nodes, still 99% relative 5-year survival rate. It's unfortunate when guys present later and have distant metastatic disease that their 5-year relative survival rates dip significantly lower at 31%. So it's really important to catch those guys early, in my opinion, and I think these numbers support that in order to have them be cured from their disease rather than potentially be their ultimate demise. So while there are typically no symptoms of early stages of prostate cancer, early detection, including PSA, which stands for prostate-specific antigen, it's just an enzyme that's secreted by the prostate gland. It has played a role in decreasing prostate cancer mortality. PSA was not invented, it was discovered in the 1980s, and it was FDA approved in 1986 to be utilized as a prostate cancer screening modality. The PSA is not a perfect test. I think we kind of all know that. And the digital rectal exam, or DRE, are complementary tests. They are the two best screening tests, even to this day, that we have to screen for prostate cancer. Minimally invasive, one's a blood test, and one is a rectal exam where gloved fingers inserted into the rectum to palpate the prostate to see if there's any nodularity or abnormalities appreciated. Also, informed men requesting early diagnosis should be given the opportunity to be tested with their PSA and undergo a digital rectal exam if they desire by their either primary care doctor or be referred to a urologist. You may not have heard, in 2012, I'm sure you're familiar with this, the United States Preventative Services Task Force data that came out. It was a panel, an FDA-approved panel of like 16 people, none of whom were board-certified urologists on the panel, and they came out with this blanket statement that was widely publicized the year before it came out in came out officially in 2012, but there was a leak, and it came out a little early in 2011, and they said that prostate cancer screening did more harm than good. And I think that statement did more harm than good, because then there was a paradigm shift. If you see for several years after that data came out, there was a shift away from more indolent disease to more aggressive higher stage cancers about 5 years after the fact, because people weren't being screened appropriately and they were being missed. So the AUA, the American Urologic Association, never recommended those guidelines. So also keep in mind that men that having any clinical picture suggestive of prostate cancer should undergo testing. Like I had a patient, he was in his early 50s, and he laid flooring for a living, and he kept complaining of back pain, and and his primary care doctor kept doing x-rays of his back and things like that, and weight loss, unintentional weight loss, but he thought he was working, he was putting in long hours, and then he started having some voiding dysfunction. He had difficulty passing his urine, and then he came to me, and I knew exactly what it was: unintentional weight loss, back pain. He had widely metastatic disease. Clinical picture, any man, honestly, prostate cancer should be on the differential, in my opinion. So again, PSA stands for prostate-specific antigen. Again, it's not a perfect test, because men with BPH or other benign conditions can have an elevated PSA. Men that don't empty their bladders well will have an elevated PSA. Men that have chronic inflammation of their prostate gland called prostatitis will have a falsely elevated PSA. Men with an active urinary tract infection, if the ER erroneously checks a PSA in the setting of an active urinary tract infection, it will be falsely elevated into double digits as well. However, men with prostate cancer may still have a normal PSA. About 15% of men I pick up have a normal PSA, but I pick it on my exam. So that's why I think the two are very, they're complement to each other, and they're very important. I had a guy last summer, PSA, he's 72, PSA is 3.1, and he has metastatic disease, picked up on his exam. Also, obviously, detecting tumors does not always mean saving a man's life. One has to be cognizant of the fact that you don't want to overscreen certain populations. Some men may have very indolent, low-grade tumors that may never harm them in their lifetime. And PSA does have a lot of false positive tests, as we just mentioned, and a lot of false negatives. So I have guys coming in, twice a year, sometimes once a year, and all they want to know is what their PSA is, So I often say PSA should stand for persistent source of anxiety. Although a lot of guys now, they already know from their, my chart and things like that. They come in and they know the answer before I do, and I'm like, oh, kind of a buzzkill. So again, PSA screening has definitely played a part in decreasing prostate cancer mortality. I can show you all kinds of data on that, but we won't get into the weeds on that. So here you can see back in 1975, the 5-year relative survival rate for prostate cancer was around 65-70%. And then here it went up. What happened in 1986, 1987? PSA was FDA approved. So that's when the screening modalities were implemented, and now we have those 98, 99% 5-year relative survival rates. So the AUA most recently updated our guidelines in July of 2023. They're typically updated, periodically based on incoming data and things like that. It shifted a little bit from the previous guidelines, but again, clinicians should begin prostate cancer screening and offer baseline PSA testing to any patient between 45 and 50, okay? They should offer prostate cancer screening, they say every 2 to 4 years. So, but that's, if they have no risk factors, you can go like every other year now. Potentially, if they have very minimal risk factors, they can go every 4 years. I find it hard to have a patient say, okay, I'll see you in 4 years, so it's kind of difficult. If they do choose to do that and they're very low risk, then that would probably be best managed by a primary care doctor with whom the patient is following more regularly. And again, we personalize screening intervals. If a patient has good longevity in their family, if both their parents live to 101, we don't need to stop at 70 necessarily. If every man in their family has had prostate cancer, all their paternal uncles, their dad, their grandfather, every male has had prostate cancer, he should start to be screened at 40. So again, we adjust those. So again, prostate cancer screening should begin at 40 to 45 for patients with higher risk. Again, race, I mentioned, African American men are unfortunately at increased risk of high-grade disease. Patients with germline mutations, there's several of these that have been identified now, including the BRCA2 gene, the HOXB13 gene, and different genes. If you are a carrier for those, you're at increased risk of higher grade prostate cancers. And then again, family history is a huge one. I always ask that, at a patient's initial visit about their history, family history. So again, patients with newly elevated PSA, this is in the guidelines that I've kind of always practiced this way, unless if a patient's exam is normal and they have one elevation in their PSA, I always say we shouldn't get our knickers in a bunch. It's recommended to recheck in a timely fashion. I wouldn't wait like a year to recheck it prior to any potential intervention with, now we have these novel biomarker tests, imaging tests, or traditional biopsy. And then the AUA, this is just, they strongly recommend shared decision making, which is basically laying out the risks and benefits to everything, really understanding, everybody has their own personal biases about what they want to do. I mean, I have patients that come to me all the time, they're like, doc, I wouldn't want to know if I had it, I don't, or they have family members that went through prostate cancer screening, so they don't want to go through that themselves. And other people, want to be checked starting at age 40 every year. They want to know, they want to catch it early if they have it, and et cetera. So everybody's different. You just lay it all out there. So prostate cancer pathology, I don't know if you've ever heard of Gleason score. Gleason score and PSA are really how we risk stratify of how we treat men once they are diagnosed with prostate cancer. It was developed by Dr. Donald Gleason actually back in the 1960s. However, it wasn't widely adopted until the 1980s when PSA became widely utilized as a screening test for prostate cancer. And most, 99% of prostate cancers are adenocarcinomas. They're given 2 scores on the Gleason score, and the pathologist reports the most predominant cellular pattern first. So you might have heard, 3+3, 3+4. I don't know if that rings a bell or not, but and to come up with a score somewhere between 6 and 10. 10 is the most aggressive, and 6 are more indolent, typically slower growing cancers. So unfortunately, once a man is diagnosed with prostate cancer, we typically use a version. I mean, nobody, it's not black or white. Nobody's every patient is not like a cookie cutter and there's a cookbook that we open up and treat them. Like I said, everybody has their own individual opinions on things and potential biases and things like that. But this is guidelines that are updated very, very frequently through the National Comprehensive Cancer Network. Right now it's up to like a 232-page document, and they update it every year. In general, like I said, we try to risk stratify people, between among having very low risk cancer down to very high risk cancer. Patients that have very low or low risk cancer could be good candidates for active surveillance in the proper setting. Patients with unfavorable intermediate risk prostate cancer or high risk or very high risk now are good candidates for new imaging modalities that we never even had like 5 years ago. We now have an excellent PET scan for prostate cancer called the PET PSMA scan that can detect little metastases upwards of like 4 millimeters in size. And it's very, very sensitive for prostate cancer. So that's been a great advancement in the last several years. So next, any questions on prostate cancer? Maybe we'll take questions at the end, I don't know. But I'd like to move on to kidney stones. That's a very common. I had a couple people acutely on my schedule today for acute kidney stones. Today is a perfect day to illustrate, like, please stay up on your fluids. Water is very important. I always see a spike in patients coming to see me, usually in late summer, early fall, from being dehydrated all summer. That is the number one, cause is dehydration and family history. So kidney stones, most people know that it's a sudden onset of extreme pain, unilateral on one side versus the other. It'd be very unusual and very unfortunate if somebody dropped down 2 stones at the same time on both sides, but I have seen it happen. But they equate it to natural childbirth. It's so bad, so it's the closest thing a guy can experience to having a baby, although kidney stones aren't nearly as cute. So if you experience any of these symptoms, blood in the urine, severe pain associated with nausea, vomiting, fevers, chills, please see, your physician right away or go to the nearest local emergency room. It could be a very serious condition, obviously, but other conditions like ectopic pregnancy, acute diverticulitis, things like that, appendicitis can mimic kidney stones as well. So again, renal colic, as it's called, is pain that kind of waxes and wanes as the stone starts marching down the ureter. Typically, we're taught that patients should only have pain if the stone is obstructing. Like this stone would be quite obstructing because it's blocking the proximal ureter here and causing pain, whereas this stone should not be causing pain, but it's at high risk of detaching from the underlying urothelium and dropping down and causing problems. So a patient like that had a stone up here, I would recommend typical prophylactic treatment at some point that's convenient for them to minimize that risk of that larger stone dropping down. Renal pelvic stones can act like ball valves and kind of like flop in and out of the renal pelvis and cause intermittent obstruction. So they affect about 9% of the US population, a little bit more common in men than women, but now that women are doing a lot of the things that guys do, eating the same foods and maybe not being quite as healthy, our incidence is increasing in women compared to men. So it's also increasing in children, likely to arise in obesity and very unhealthy eating habits. So prior to the development of our modern urologic treatments, certain stones like the staghorn infection calculi, mortality or death rates from them were near 30%. And a family history of renal calculi is present in 55% of patients with recurrent stones. So like I said, you can't change your family, but you can modify various risk factors, especially your fluid intake, to mitigate risk of forming new kidney stones. So the most pressing issue in managing stones is determine like what patient needs urgent versus not urgent intervention. The gold standard for diagnosing an acute renal colic attack is a non-contrast CT scan. You can see this patient here has a good-sized renal pelvic stone that's obstructing them on the left side. And workup always includes sending a urine culture to evaluate for signs of infection. You'd want to check a CBC or complete blood count to assess for an elevated white count, check their kidney function to assess for any derangements above their baseline, to determine if they could ride it out. That's kind of a big stone to ride out, but because patients can safely be obstructed without setting of an infection for up to 6 weeks before it does any permanent renal damage. So sometimes you'll allow a patient several weeks with pain medication, medical expulsive therapy, a medication called tamsulosin that we'll talk about later for BPH can help medically dilate open the ureter and help them pass their stones more readily. So signs of urgent intervention, again, if a patient has in the setting of infection, bilateral obstruction, again, rare, but I have seen it happen. Obstruction, some patients only have one kidney. They had a kidney removed for various reasons. They were born with only one kidney. They suffered a trauma, etc. If a solitary kidney becomes obstructed, you got to take care of it right away because they will be in severe renal dysfunction. If they're immunosuppressed in any way, that includes diabetics, patients that are on chemotherapies, chronic steroids. We try to intervene on those patients sooner because they can kind of turn the, get sick real fast because they don't have an immune system to mount against the potential impending infection behind the stone. Patients that come into the ER and they just cannot get their pain controlled, they get admitted and usually like stented, and patients with intractable nausea and vomiting because they can't take down the oral pain medications to go home, so they often will get admitted. And so here's a chance of passing ureteral stones. Kind of drops off precipitously when the stones are 7 millimeters or greater. But here you can see a very high likelihood of passing small ureteral calculi when they're less than 6 millimeters in size. So calcium oxalate stones are the most common type of stones. There's various factors that promote urinary or calcium oxalate stones, but the number one cause is dehydration. So water, water, water. You want to drink enough fluids to make a minimum of 2 to 2.5 liters of urine output a day. So imagine filling up a 2-liter soda bottle full of pee every day. Like that's how much your target volume should be to keep your urine as dilute as possible without overdoing it to mitigate your risk of calcium oxalate stones. There's also conditions that precipitate something called hyperoxaluria. Got people that have had gastric bypass surgery, they don't metabolize oxalates well, and it combines with calcium, and they are more likely to form calcium oxalate stones. Other inflammatory bowel diseases increase the risk of calcium oxalate stones, as well as hyperparathyroidism. So this list is far from being totally inclusive of foods that are high in oxalate. A big one is tea. So don't drink a lot of iced tea in the summertime because black tea is very, very high in oxalates if you're a stone former. Also, black pepper is high in oxalates too. So again, there's a lot of online resources to look up. This list is far from being totally inclusive, but this just gives you an idea of different foods. Most people know that, a lot of people know that chocolate and spinach are very, very high in oxalates. So, I mean, I literally had a patient, she thought she was getting healthy. She was putting spinach in her smoothies in the morning, eating a large spinach salad at lunch, and then eating, fish and the spinach as a side vegetable, and she started forming stones. Other thing that causes calcium oxalate stones is vitamin C. So don't take too much vitamin C because it's ascorbic acid and it's converted into oxalic acid in the body. So, people in the wintertime pop a lot of vitamin C thinking it's going to ward off all colds and flus and things like that. But, if you don't drink enough water with it, it can lead to stones. These are some foods that are low in oxalates. So water with lemon. Lemon has, citrus foods have citric acid in them, which is a natural inhibitor of stone formation. But I always tell my patients that even natural things have side effects because all the acid, in the lemon juice can erode the enamel on your teeth and things like that. So there are pills that we can supplement the citrate with, or drink a lot of lemon water through a straw to minimize the contact time with your enamel. Coffee is low in oxalates, and some of these other vegetables. About 20%, this is the second most common type of stone, is uric acid stones. This is a product of purine metabolism. This is the symbol of purine there. Purines are just, they're like the building blocks of our DNA and RNA. Not only are they in food that we consume, but our body also produces purines, so you can't really get away from them. The great thing about uric acid stones is that it's 100 times more soluble at a pH of greater than 6 compared to a pH of less than 5.5. So this is one of the few stones that we can actually play chemist and change the pH of the urine with various medications and dissolve these types of stones, as long as we know that the stone is a uric acid stone, which we have different ways of knowing that. If a patient passes a stone, we send it for chemical analysis. We get clues based on the patient's urine pH and how it looks on CT scan imaging. So the most common risk factor for uric acid is persistently acidic urine. So if we can make the urine a little more basic, not too basic, but a little more basic, we can actually dissolve uric acid stones. A lot of people think, they automatically have gout if they have uric acid stones, but that's not true. Patients' gout or hyperuricemia is only associated about 20% of the time of patients with uric acid stones. Other conditions such as insulin resistance or diabetes leads to uric acid stones, and you can have mixed composition too, as a side note. Like not all stones have to be 100% uric acid. They can be 80% uric acid and 20% calcium oxalate. But because diabetics are typically in a little bit of a ketoacidotic state, they're a little more acidic, their blood, compared to non-diabetics. So they're at higher risk of uric acid stones. And patients undergoing chemotherapy, because the chemotherapy lyses or opens up hundreds of thousands, if not millions of cells during the rounds of chemotherapy, it releases acid into the bloodstream, and patients can have form uric acid stones. Struvite stones, I mentioned briefly, are known as those infection stones. They're formed because of urease-producing bacteria. E. coli is not one of them. The most common urease-producing bacteria is Proteus mirabilis. Other pathogens include Klebsiella, Enterobacter, or Pseudomonas. Patients can form very large, very rapidly, filling sometimes the entire renal pelvis or calyceal spaces of the kidney. Treatment involves antibiotics and complete surgical removal of the stone and all of its fragments. Because under the microscope, all stones kind of look like little pumice stones, and they can have all these nooks and crannies that bacteria can hide in. So these types of stones, you have to surgically remove all the stones. Here's an extreme example. This is in the New England Journal of Medicine. This patient underwent an open pyelonephrectomy on the left here. Here you can see the entire renal pelvis, the proximal ureter, and the entire calyceal system was filled with stone. And then they underwent a PCNL, which is a percutaneous nephrolithotomy, to treat the left side. Not sure what their ultimate renal function is or anything like that, but that's pretty impressive. So prevention of kidney stones, we've talked about a few things already, but drink enough fluids to make at least 2 liters of urine a day. I used to live in Georgia for a little bit, and I had some Georgia roofers as my patients, and I mean, these guys had to drink gallons with all the sweating they had, all the insensible losses they had being up tarring these roofs and things like that. So it's not drinking 2 liters a day. You want to drink enough to have that output. So everybody has different levels of losses. If you have a chronic diarrheal state, if you sweat a lot, different things like that. So that's your target volumes. In general, avoid those high oxalate containing foods that we talked about: vitamin C, spinach, tea. So again, the black tea is the worst. Like if you drink chamomile or green tea, not as bad. So if you love tea, switch to those. And different beans like fava beans, navy beans, baked potatoes with the skin, strawberries, and rhubarb. So no strawberry rhubarb pie. Also decrease salt and salt intake. High salt intake increases calcium excretion of the kidneys. And for those uric acid stone formers, they should avoid high animal proteins, because that acidifies the urine. Okay, so options if a patient does have a symptomatic stone, an enlarging stone on serial imaging, recurrent urinary tract infections, and they need the stone to be treated because it's a nidus for their infections. There's various treatment options. Again, uric acid stones only. We can potentially dissolve them. Most people have heard of, ESWAL or extracorporeal shockwave lithotripsy, where we send sound wave energy through the back to the kidney in a targeted fashion to help break up the stone into small pieces, and then the patient is allowed to pass those pieces. Ureteroscopy is a method where we go up inside endoscopically into the ureter with a little camera scope, visualize the stone, whether it be in the ureter or up in the kidney, and use a laser fiber to break it up into small pieces. And then we either pluck some of the pieces out with a little basket, or they're just such small pieces that the patient easily passes them. Percutaneous nephrolithotomy, I mentioned it on a previous slide, where we can go in through the back. It's a little morbid and painful, and access, through a surgical incision through the back into the kidney to treat large stones. Nowadays, with the advances in our lasers and small, instrumentation, you have to have a pretty big stone, in my opinion, to warrant the PCNL at this point, because we have so many good ways of treating them less invasively. And then in rare cases, an open lithotomy, like I showed you that surgical specimen of that stone, like it was basically a cast of the entire kidney. Next, I'm going to talk about, I'm just going to get a sip of water, recurrent urinary tract infections. So, the elderly population are more likely to experience recurrent UTIs, as well as women. Women are 40 times more likely to experience UTIs compared to men, basically because of our anatomy, which I'll show on a future slide. Older individuals are also more vulnerable for various reasons, including a potential weakened immune system, certain conditions such as diabetes, medications. They have all those diabetic medicines that dump all the sugar into the urine. I mean, bacteria thrive in warm, moist, sugary environments. So I'm not a big fan of them. Menopause, that changes the hormonal milieu down there. So a lot of women can increase their risk of urinary tract infections after being postmenopausal. Younger people in general tend to empty their bladders completely, whereas as one gets older, for various reasons, they don't empty their bladder well, various neurologic conditions, bad habits. I mean, I honestly have nurses and teacher patients where they hold their urine all day long and they're not, urinating during their shifts, or they can't leave their, 2-year-old classroom, unattended. So they're holding it for 6-8 hours at a time. And then over time, that does some damage. The bladder becomes almost like an overstretched rubber band where it just doesn't squeeze hard enough anymore, and it stores very, very large volumes of urine. And that, again, is a nidus for recurrent infections. So again, God is a great designer. However, some of my patients would argue that for females, our holes are a little too close together. This is the opening to the urethra into the bladder here. This is the vaginal birth canal opening, and here's the anus. Men, their holes aren't that close together, and then they have the long pendulous urethra that really inhibits bacteria from going retrograde into their bladders, and that causes us to be 40 times more likely to have a urinary tract infection. So typical signs and symptoms of a UTI, most women know these. Women that may appear dark or cloudy, you might actually have blood in the urine. You could have strong, foul-smelling, urine, frequent need to urinate. You just feel like you're not emptying completely. Pain, we call it dysuria. It's very painful every time you urinate. It feels like razor blades. Pressure, sometimes it's associated with a low-grade fever, and things like that. However, when patients become older, sometimes they don't exhibit these typical signs and symptoms of UTI. Elderly patients, in nursing homes and things like that, can actually present with confusion, worsening, sundowning and dementia-like symptoms, agitation, hallucinations. So it behooves, whoever may be taking care of them, if they present with some of these symptoms, to check their urine and make sure they don't have an infection. So tips to help reduce the risk of infection. Again, fluids. Water is really important. It helps, you want to flush that bacteria out of the system, so you got to drink. Change any potential undergarments or briefs, promptly if soiled. Keep the genital area clean. I have some patients that have fecal incontinence symptoms. They suffered a terrible 4th-degree tear during, vaginal delivery, and they just don't have good control. If they have loose stool, they're fecally incontinent. So that's not good for, urologic health either. Urinate after sexual activity. Let's see here. Those who not only memory impaired, but even patients that just get busy and they kind of forget that they have to go to the bathroom, I recommend time voiding about every 2.5 to 3 hours. That's normal for daytime urination. You want to go every 2.5 to 3 hours to keep the bladder empty. There's certain over-the-counter supplements. Sometimes I recommend D-mannose. It's a sugar molecule that's not absorbed by the body, so even diabetics can take it. And it helps prevent the pili from the most common bacteria that sets up shop in the bladder called E. coli from attaching to the urothelium. And it can be a game changer for a lot of patients. Some studies have recommended vitamin C, and that acidifies the urine. Again, you don't want to do too much because then you can form kidney stones and all this other stuff. But I find patients with recurrent UTIs, a lot of times they have some urgency and frequency, and that acidifying of the urine with vitamin C and cranberry can be irritating to them, and it can worsen like frequency and urgency and things like that. You also have to drink a whole lot of cranberry juice to make it make a difference. So if you're interested in doing it, I would just recommend an extract and a pill. Cranberry juice also has a lot of sugar in it too. So this is the one I typically recommend. And separated by several times a day to keep that coating in place. It almost like Teflon coats the lining of the bladder to prevent bacteria from sticking to it. And then topical or vaginal estrogens for those with atrophic changes that are postmenopausal. That can be helpful too. They just apply topically 2-3 times a week before they go to bed to replenish that hormonal milieu down there that they lose after menopause. And lastly, I'd like to talk about BPH, or benign prostatic hyperplasia. This is a benign condition as opposed to prostate cancer that we talked about first. You just get adenomatous overgrowth of the prostate here, and it causes compression of the prostatic urethra, and it can lead to voiding dysfunction and difficulty emptying one's bladder, straining to void, and things like that. So guys will complain that they feel that their bladder's full even after urinating. They will urinate frequently because they feel like they have to go all the time. Urgency, they feel like they can't wait. They have a weak urine flow. I often, not on a day like this, but I'll say, hey, can you write your name in the snow anymore? You know, if you had a stream and things like that. Dribbling, this urinary stream has hesitancy where it stops and starts several times. Need to push or strain, and getting up at night more than 2 times. So there's a little survey. I tell my staff, any guy over the age of 50, I don't care what he's coming for me. I have him fill out the survey on his initial evaluation just to assess for any BPH symptoms. It's called the International Prostate Symptom Score, and it basically asks all those questions on a Likert scale, and a guy will circle 0 to 5, depending on how severe his symptoms are, and we score it, and it just gives an assessment if a guy needs treatment, if we would recommend treatment. Some guys don't. Some guys want treatment if their symptoms are mild. Everybody's different. So age is the biggest risk factor. Like I said, anybody over the age of 50, I give them that survey because that's when these things start to rear their ugly head. Nearly 80% of men will develop some degree of BPH in their lifetime, and over 30% will receive some sort of treatment for it. And again, family history, can't change your family. Those with a first degree relative, usually their dad had a big prostate and they have a big prostate, and it increases a guy's risk of having issues. So medications still are the first line treatment for BPH, and they're often used in combination with behavioral therapies. Caffeine is known to be very irritating to the bladder. Guys that complain of getting up too much at night, we'll give them behavioral techniques like don't drink 6 beers before you go to bed. Maybe you won't get up so much, and things like that can be helpful. But alpha blockers, a lot of them are generic now. Tamsulosin, also known as Flomax. There's doxazocin, aflazocin, known as Uroxetrol, Silodosin. What they are medications that are very specific for the urinary tract that help relax the bladder, neck, and the prostate, and kind of medically kind of pull apart the 2 lobes of the prostate in a sense. And that typically they take a few weeks to reach maximal efficacy, but usually at my guys' 3 to 4 week follow-up, they're reporting that they're urinating significantly better. And there are tests that we can do to prove that, like there's Uroflow tests to see, how fast they urinate, compared to before treatment and after treatment and things like that. And then there's the class of medications called 5-alpha reductase inhibitors, which include the finasteride, also known as Proscar, or the dutasteride, known as Avodart. These help, honestly, shrink down the prostate over time, upwards of 25%. They do artificially lower the PSA, so there's other ramifications of it. They also help prevent male pattern baldness, so there's good things. They can potentially cause possible sexual dysfunction and gynecomastia rarely. So those are potential side effects, but there's a lot more good than bad with them. Some studies have shown it actually decreases potentially the risk of low-grade prostate cancers, but it is not FDA approved for prostate cancer prevention in any way, shape, or form. For surgical treatments, the gold standard and the most commonly used treatment is still the good old-fashioned TURP, which stands for transurethral resection of the prostate. It's minimally invasive. Again, it goes endoscopically through the natural orifice of the male urethra, and it's a special scope that, like I said, can resect or there's a button electrode that kind of melts the tissue away like a hot knife through butter. They're all, different ways of skinning a cat, so to speak. You can use a laser to do it. You can, they're all, slightly different modalities. But again, it's a way of opening up that prostatic channel to alleviate the compression on the urethra. So again, other alternative treatments is this procedure called the Urolift. Basically, that technique kind of picked up in popularity about 10 plus years ago, and it's a way of like stapling the lobes apart. I've never liked the idea of leaving a foreign body inside the urethra because these metal and surgical staples stay within the prostatic urethra after they're deployed. And I just didn't like that. I thought it could lead to stone formation and things like that. TUIP is transurethral incision of the prostate. That's where we incise the prostate strategically in a couple different areas to help open it up. And that mitigates the risk of sexual dysfunction called retrograde ejaculation. There's also the tuna needle ablation. Again, these are all different ways of skinning a cat. We are trying to open up this channel to create, to alleviate the obstructive process there. There's microwave therapy, aquablation therapy, and now the newest and latest and greatest is this procedure called the iTind. It's a temporary implanted nitinol kind of stent that we put inside the prostatic urethra for 5 to 7 days, and it causes like ischemia in strategic areas, kind of like it's a mechanical TUIP basically. Here's a slide on it. So it's deployed inside the prostatic urethra, left in situ for 5 to 7 days. It's an outpatient procedure, and then the patient comes in and this basket is removed and it opens up the prostatic channel. And the longevity of that is anywhere from 5 to 10 years, and it doesn't cause that retrograde ejaculation sexual side effect. So it's a good option for the right candidates. All these, patient selection is very important, So I think that's about it. Okay, so what to expect at your initial appointment if you decide to come see your local friendly urologist. You'll be given initial paperwork and an interview to assess your symptoms. Like I said, you might have some surveys to fill out, like the IPSS. Adams questionnaire is something I use for guys that are complaining of potential signs and symptoms of low testosterone. Please, 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 if you've ever seen another urologist or had any pertinent records, I know we have computerized medical record systems, but they do not all communicate together. So if you went to Hammett and for renal colic and were diagnosed with a kidney stone, try to have your films burned onto a CD-ROM. So if you go to another urologist, they can see what's going on, because otherwise they don't. You can see the report, but I always like to look at the films myself. Any outside records, if you had surgery, 5 years ago at the Cleveland Clinic by a urologist there, it'd be nice to know what exactly they did and, and whatnot. You would be asked to give a freshly voided urine sample that day to evaluate for blood, signs of infection, and then I check every patient for their emptying ability. After they urinate and give me a specimen cup, they feel like they finish emptying into the toilet, and then we check a PVR with a bladder scanner to make sure the post-void residual volumes, what that stands for. Undergo a physical exam. And any additional testing, depending on why they're there. If they're there for blood in the urine and they're a long-time smoker, I might be concerned about bladder cancer, so I might send a urine cytology test, might set them up for a cystoscopy where I look inside the bladder, have them perform a voiding diary to evaluate for nocturnal polyuria if they're complaining of getting up too much at night, might set them up for that uroflow test that measures how fast they urinate, another test called urodynamics. I mentioned the bladder is a muscle, so a test that we do in the urology world is like an EKG test for the bladder muscle called urodynamics. It can tell us how well and how strong it's contracting, if it's contracting inappropriately and things like that. And might order upper tract imaging if there's suspicion, if there's blood in the urine or a suspicion for stones, etc. A TRUST stands for a transrectal ultrasound. There's all kinds of things that we can do. And then obviously schedule follow-up as planned to review the results of any of these tests. And that's it. Any questions? Yes, sir.
I'd like to ask a question about prostate cancer
Yes.
diagnosis. So, how do you diagnose that for people above 80, let's say?
Above 80? Yeah, well, still, if we're still screening for it, if a patient still desires, to be screened, so that if a patient still desires to be screened at 80 years of age, depending on their longevity and risk factors, it's diagnosed still by the PSA. well, I don't know, I mentioned it on my original slides, but the PSA, prostate-specific antigen, and the rectal exam. Okay, if either one of those is abnormal, we could set the patient up for a formal prostate biopsy, which is a transrectal ultrasound biopsy of the prostate, where we perform a 12-core sampling of the prostate, 6 cores from the left, 6 cores from the right is standard. There's also, like I said, novel urinary biomarker tests if a patient's PSA is equivocal, because there's age-adjusted normals for PSAs. A man in his 80s is allowed to have a higher PSA compared to a man in his 40s. A guy in his 40s, his PSA should be less than 1. 4 is not normal for him. There's also, we utilize MRI now more frequently to target potential lesions called PIRADS lesions within the prostate, and then we can try to target those, any suspicious lesions. They claim more targeted than with ultrasound, with something called an MRI fusion biopsy. And then lastly, there's something called the transperineal biopsy. So instead of going through the rectal tissue, we go through the area between the scrotum and the anus. It's done in the operating room under general anesthesia and target the sample the prostate that way. But that's still, we have to get tissue one way or another to actually diagnose it.
Yeah, like you said, mostly it has to be at the request of the patient. No, they wouldn't do it like this.
Well, if they're coming to see me, I mean, I have a different practice than like a primary care doctor, whatever their relationship is with them. If they want to continue prostate cancer screening, I did mention, like, if a patient wants it, I think it's warranted. I mean, I diagnose guys in their 80s. I do, especially if they have symptoms. Like, you'd rather want to treat them and diagnose it and treat them accordingly, in my opinion, than just assuming, that they're going to live with it and die, with it rather than from it. Mm-hmm. Yes, ma'am.
I was really surprised to see the slides about the food.
Mm-hmm.
It's like opposite of everything I've understood over recent years of reading everything, and particularly because a lot of those foods are what you talk about, they have good gut health, which of course has been high on my mind. So I've been eating all those things like crazy, right?
Yeah,
And
moderation's the
lettuce,
key.
which I've always heard had no nutritional value, and romaine and all the other ones are better.
Yeah.
It's almost, and then a lot of those are beans. The beans, which everybody is pushing beans. It's a protein alternative, right? Everybody's saying don't eat so much animal meat. Replace it with beans. So that's shocking. And then that same slide later on said, well, don't eat animal meat either. So I thought
For the uric acid stones, yeah.
Yeah, and I noticed
Moderation's the key to life, though.
It didn't say moderation, so it kind of said don't eat any of those things if you want to have, not have any urological
Well, that's
issues.
for patients that are prone to forming kidney stones. I mean, if you never had a kidney stone in your life.
And you did qualify and say if you are, make sure you drink a lot of water. So it's the message to take home is that if you're eating these to balance out all the different things in your body you're trying to control, make sure you're drinking enough water. And that it's okay to eat them.
Yeah, in moderation too. I mean, like I gave the example of the woman who never had a history of kidney stones, but then she literally started eating spinach for breakfast, lunch, and dinner, and she started forming stones. So moderation's the key to life. I mean, in general, like you can eat it, several times a week, but don't eat it 3 times a day.
I drink coffee.
Is it because spinach and some of those other vegetables have high calcium?
High oxalates. That was specifically for
What are
oxalates.
oxalates?
They're substances in certain foods, and it combines with calcium either in our blood or our dietary calcium and can form kidney stones, the most
So
common
it's-
type of kidney stone.
So it's not the calcium itself, it's the oxalates.
No, in rare cases, we actually, believe it or not, prescribe additional calcium to mitigate kidney stone risk. So yeah, we never tell people to cut out calcium. I never said that.
An average sized person, maybe it's different for men and women, but an average weight person, whatever, is there a ballpark how much water should be targeted to drink every single day?
Fluids?
Ounces, yes.
No, I don't, again, I mentioned that I don't recommend, everybody's different about how much they need to consume. What your target is the output. Output.
Oh, so whatever you need to drink to get that output.
To get that
on a
output.
daily basis.
Now, obviously, there's other risk factors. If somebody has CHF and they're on a fluid-restricted diet, like that goes out the window and things like that. But yes, your urine should typically be a light yellow color, and target volume is 2 liters of output a day. So everybody's different. Like I said, for all the insensible losses, like my roofers that are doing my roof right now, they're, called it quits early today because they were probably sweating pretty good today. So they really need to keep up on their fluids, and being out on the tennis court, golf course, on a day like today, you got to keep up on the fluids. And so that's not drinking 2 liters. That's probably drinking, more than that. Mm-hmm. I mean, you can go to Dollar Tree and get a container and measure it just for your own, interest or whatever. Yes, ma'am.
So, you spent a lot of time talking about prostate cancers in men,
Mm-hmm.
which is great because we take care of our men.
Mm-hmm.
But what kind of cancers do you see? Is it bladder cancer or what?
Yeah, you can get, on the previous slide, you can get cancer all along the urinary tract. Kidney cancer, adrenal cancer, urethral cancer, bladder cancer. Women can get urethral cancer as well, is extremely rare. Mm-hmm. Yeah. Yeah, so anywhere along the urinary tract, you can get cancer. But I focused on prostate cancer because it's so much more common. 300,000 cases a year compared to, the next most common cancer is only 80,000 cases a year.
How can you tell when you have overactive bladder that's actually that and not just the result from drinking too much or too much water
Output.
on a day? And so
Yeah. Well, output. If you're putting out 4 liters a day, I'd say that's a little excessive. You know what I mean? Because your target output is about 2 liters a day. So that would be a little bit of polydipsia, in my opinion. So yeah. Overactive bladder too is, it's not related to fluid intake or, intake. They have, frequency and urgency despite fluid intake. Yes, ma'am.
I don't want
Go ahead. You're okay. You
anyone
have
else
all yours.
to ask a question. Okay. What about frequent urination at night?
Mhm.
What's normal? What
Yeah.
should we start to worry about?
Yeah, we usually a great 2 or more times a night. It gets to become a nuisance for most people. I have people that get up 6, 7 times a night and they have no problems. They go back to sleep easily and they're not bothered. I have other patients that get up once or twice a night and they can't fall back asleep and they're incredibly bothered by it. So bother is an important, factor with all that. You have to evaluate for something like I briefly mentioned, nocturnal polyuria. It's a derangement in responding to a certain hormone called DDAVP in the body versus the body not producing enough of it. And that's evaluated by avoiding diarrhea to see if you make more than a third of your total urine volume just at night. We can potentially replace that hormone with a little pill or an intranasal spray, and it can potentially cure
So-
nocturnal polyuria. There's other issues, there's a plethora of reasons.
So it can't be more than just an inconvenience. It could be a sign of
Yeah, and it can have long-term sequelae, especially for elderly people that have poor mobility, poor eyesight. They're getting up multiple times in the middle of the night, can lead to falls, and all this other stuff. So yeah, it's, oftentimes a condition that it's not unusual to want to treat. Yes, sir.
I'm familiar with the procedure called the resume procedure.
Mhm.
You didn't mention that.
Yeah, it's the aquablation. That's the brand name for the aquablation procedure. Yeah. So it's same thing. I just mentioned the iTime because that literally is like the newest thing on the market. But yeah, and the Urolift, they're all brand names. But yeah, the aquablation is the resume. Anything else?
I have a question that might be a little different. Change in administration and all the changes at CDC and all that, are you seeing any changes that's coming down to you?
I haven't witnessed anything though. Mhm. Yeah. Anything else? All right. Well, thank you. Thank you for spending your anniversary with me.